Hello, I'm Dr. Diana Bitner. I'm here with Dr. Maria Sophocles from Princeton, New Jersey. Hey, Maria, thanks for joining us tonight.
Hi, Diana. Thanks for having me.
We're here for a Let's Chat, one of our recurring episodes. Tonight, we're going to talk about all things sexual health, and with a special focus on the MonaLisa Touch. That is how I met Dr. Sophocles. She taught me how to do the procedure and has done, I don't know, Maria, if you've done more than anyone in the United States, but I bet pretty close.
Yeah, definitely up there, but that's only because I got to start first, so it's kind of
Awesome.
unfair.
Well, good for you. Just a little bit of housekeeping. Everyone, I want you to stay tuned for our episodes of Let's Chat in September. We'll be talking again about sexual health as it's Sexual Health Awareness Month. It's also Ovarian Cancer Awareness Month. So that's something that we definitely want to make sure that people are aware of, and I look forward to doing a deeper dive into that. And then, of course, in October, it's Get Back to Your Health and Breast Cancer Awareness. A quick also housekeeping is that the guest list of people who are attending tonight has been kept private. So if you RSVP'd for this, I know this can be a bit of a sensitive topic. And so just know that the guest list has been kept private and you don't have to worry that your friends and family will see that you're watching this. We try to be sensitive to that, of course. If you send in private messages on the Facebook page, then Missy, who does our communications, will make sure and send that to me in the private chat room, so no one will be able to see that you asked it. We did get one question ahead of time, which is a little sensitive, so we'll make sure and address that question as well. I always like to start these Let's Chats with why I care about this. And then we'll ask Dr. Maria the same thing. So I care about this because sexual health is such an important part of women's health. When I was a busy OBGYN, I never really asked people about their sexual health because, frankly, I didn't really know what to tell them if they said that there was a problem. And I've been very blessed to get more education at several national organizations, a lot of study on my own. And now I've been blessed to take care of patients for over 5 years with very specific questions about sexual health. And one thing that really comes to mind is women who suffer from painful sex or painful intercourse. It is so unnecessary to suffer.
Could you try?
And sorry, my Siri was talking. So it's something that painful sex can be such a big deal because women feel ashamed and broken and isolated, and they just cry with wondering what is wrong with them. So that's why I care about talking about this tonight. And we're going to do a deep dive into different causes and options for painful sex. So Dr. Sophocles, why are you here tonight to talk about this?
I'm here because I share your feeling that it's a very underrepresented topic in terms of the precious and intimate time between a clinician and a patient. We get so busy doing a pap smear and ordering a mammogram and getting on to the next patient that it's easier for a lot of clinicians to simply forget or feel awkward about asking about a woman's sexual wellness. And so there's sort of a double, societal awkwardness about it. Women feel awkward talking about it. Doctors and nurse and mid-level providers feel awkward bringing it up. I would say probably mid-level providers actually feel more comfortable bringing it up in
general. Do.
But the point is, it's sort of a don't ask, don't tell thing, and women kind of keep this dirty little secret. And this feeling of brokenness or past their primeness. And just like you have, I've had women come in tears saying, I love my husband, but I think I'm broken and I think it's just me. And women don't really talk to each other about it either. I mean, maybe a little bit, but there's a lot of misinformation, I think, about the link between the lack of estrogen, menopausal lack of estrogen, and sexual function. It's amazing how if you ask women about menopause, they'll say hot flashes, and they know that's a link. But if you ask them about vaginal dryness, they think it's just something that happened to them. They don't realize it's often related to menopause or what it is related to.
Right, and that it's a medical condition that can be treated. They often think it's just part of aging, or even, with more women, let's say, getting bacterial vaginosis in menopause, when the pH is off of the vagina, they think, well, my grandma was stinky, my mom was stinky, I'm just going to be stinky as I get older. So even just very simple things like that make people feel older or dirty, or, it's just, I love seeing the aha moment when people say, what, I don't have to live with this, there's an option.
Right. And that it's safely treatable. There are things treatable in medicine, but there's a big price you pay or risks of really severe side effects. And the treatments by and large for vaginal dryness and even for sexual pain in general are very low risk. They're very well studied. Most of them are FDA approved, and they're really just about opening that door and asking your clinician, is there anything you can do for me?
Exactly.
And also understanding that some clinicians, even OBGYNs, are not comfortable or not trained to really offer options, which was sort of a shock to me. Right.
I wasn't, right. And I'm just busy delivering babies and doing surgeries. And, even thinking about women after they have babies, when that placenta comes out, the estrogen levels drop to nothing. And especially for that first 6 months while people breastfeed, that vaginal estrogen level can be so low that it can cause painful sex or bladder urgency. And again, women think, oh my gosh, I've got an infection or there's something wrong with me. Or when no, it's just low estrogen that causes that dryness. So,
or on a low dose pill.
Or on a low dose pill. I've seen 2 patients in the last couple of weeks that, are, women, let's say in their early 30s, they're on a low dose birth control pill and their vaginal tissues just look like just a woman who's 70. So it's really important that we clinicians, again, ask the questions, think about it. It's not rocket science.
Right. And hopefully educate our colleagues, because one of the most dramatic patient types that I see are breast cancer survivors or GYN cancer survivors who are on an anti-estrogen regimen of medication that's preventing recurrence of their cancer, which is great, but it's turning the vagina into, the desert. And so you'll have 40, 45-year-old women coming in, and they're so happy to be finished, to have, quote, conquered their breast cancer, but they feel betrayed. They say, no one told me that I could get through lumpectomy and radiation only to lose my femininity, lose my ability to have sex, lose a significant part of my relationship. And I find that to be, as many women tell me, it's as emotionally destructive as the cancer itself. And many oncologists are so good at treating cancer, but they don't ask.
Right, they don't ask. And so I was so honored to have a clinic for a couple of years called Cancer, Menopause, and Sexual Health. And now that I started True on my own, and Suzanne Pettigrew, an incredible PA, has joined me. She specializes in cancer survivorship. So I'm so honored to be able to offer treatments to patients who suffer these cancers, especially in terms of what we'll talk about tonight with the MonaLisa Laser Touch. But, I had no idea, even taking care of young women with anal cancer who have radiation, and just have such terrible dryness. And when they start to be able to have sexual function again, even if it's just outer course before we can get to intercourse, even just to feel a little bit more normal and connected to their partner again, it's such a gift. And again, I can't believe I get paid to do this, right?
I know. We've experienced the joy of delivering babies and taking out tumors, and there's so much, I think, in our profession that we do that is gratifying, right? These projects, but this is different. And I think for both you and I, especially as we're aging, we're finding, yes, we can relate. We can see how, as you age, you worry that are these aging facets. And in many cases, it's not. It's so treatable and reversible. So I can't wait to hear how you explain to everyone all the ways we can treat it.
Yeah, it's so great. But what I want to first talk about, what I've really learned, is that women, of course, want to know solutions. But the first thing that they want to know, that I would want to know, is like why these things are happening. Right. And, sort of talking about, let's say, the woman who just had a baby or the woman on a low dose birth control pill, that brings up a couple reasons for painful sex. So I kind of like to think about it in zones, essentially. So women tend to have pain with sex either because of the skin on the outside, the skin on the inside, or because the muscles in the pelvis. Mm-hmm. A fourth reason would be conditions way on the inside, let's say endometriosis and scar tissue and inflammation that happens because of endometriosis implants, which of course is a huge problem. And in talking about maybe something that we're just learning more recently about is high tone pelvic floor dysfunction. So Marie, I don't know what your experience with this is. I would imagine a lot. But for example, if a woman's had painful sex in the past, then her muscles will have memory of that. And when she tries to have intercourse again, those muscles just clamp down, for lack of a better explanation. And I think about the bowl of the pelvis, the bones of the pelvis. are lined by muscles that go this way, and they go around each opening, around the urethra or the bladder opening, around the vagina, around the rectum. And those muscles are just so important because they keep our BM and our urine up where it's supposed to be, the baby's up where it's supposed to be, but let them come out when we want them to be. It's a very complex organization. But women will say, it feels like he's hitting a wall. It feels like I just close up.
Right. And that is the term we used when we were training was vaginismus,
Yes.
which is a psychogenic thing, but that doesn't mean you're crazy. It means your brain feels, your muscles sense the discomfort. Your brain tells the muscles to go ahead and resist and clamp. And when you do that, you make the intercourse more painful for yourself. But it is not something you can just will away. I wish it were that easy. But it is something that a pelvic floor physical therapist, what's that? That's a special type of physical therapist trained to understand that beautiful muscle and bone relationship. And they can work much more in a much more detailed and patient and robust way than Dr. Bitner or I have time for, really, to help women learn to find the muscles that are tense and relax them. We also can give, we sometimes give injections. We do injections into the muscles to help relax them. So if it's a muscle problem, that is fixable, but it's definitely a reason, and it's not an infection, and it's not cancer, and it's not a disease. And very few women understand that their own muscles are working against them.
Exactly. And I think about too, for example, I had a patient who was an elite runner. She ran in college, D1, and now she still runs a lot of miles, and she'll stretch. But, when we're young, right, we think we can kind of just keep going. So her hips are so tight, they're turned in. Her core is really strong, but because of that, her muscles are just so tight that it's really painful for her to have intercourse. Or let's say even people who have a hip surgery and don't stretch, those tight pelvic floor muscles can make the bladder feel like it has to contract, like it can't hold much urine. Also, I had a patient with such a tight pelvic floor, she really had a difficult time having a bowel movement because the BM had to kind of make it around the pelvic floor. It couldn't just come straight out. And so, we were able to treat her, of course, with pelvic floor physical therapy on the inside, but also really teaching her hip openers, to go to YouTube or the Peloton app and do yoga, do hip opener exercises. And the other thing that I was able to prescribe for her is vaginal Valium. So it's a Valium pill that relaxes muscles. You just get it wet, put it in the vagina, and it actually relaxes the pelvic floor. That's how we were able to help the woman have a bowel movement again, by using that vaginal Valium before a BM. And of course,
you can do it before intercourse, or you could do the vaginal Valium before intercourse, or even before pelvic floor physical therapy for a while if you need it. It's a lovely,
get over that fear.
Yes, it's a lovely way to help cheat. I had an accident on a skateboard in my late 40s, which was really just poor judgment, and fractured my coccyx. And I couldn't operate. I couldn't sit to operate or see patients. And I tried the vaginal Valium myself, and it was incredibly helpful. So always good as a doctor to try something and then you really understand. But I do think it's been a wonderful go-to supplement for patients, and it can be very inexpensive. If there are ways to order it very inexpensively.
Yes, good. But the other thing too that we offer at True, but one can get it online, is the Milli dilator. That's MILLI. So Milli is so great because Milli, once the dilator is inside the vagina, woman can hit the button on the handle and it goes up as big as is just barely uncomfortable to help train those muscles to relax. How else do you get into those muscles? You can't go to a pelvic floor physical therapist every day. And the other thing is something called an O-nut, OHNUT. We sell them in the office. Again, you can get them online. But it's essentially, for a woman who has sex with a man, it's something that you can put, you and the partner can put on an erect penis. And essentially it's stackable, soft little pillows that stack right and allow only a little bit to go inside. So it helps take away that fear of that pain with penetration.
And then also positions, Diana, encouraging women to control the depth of penetration with sexual position. Woman on top, for example, has the best ability for a woman to control the rate of penetration and the depth of penetration, and that's free and easy. And that way, that'll give a lot of women the comfort of feeling power.
So you don't have to worry about the fear. So again, for people who feel like there's a wall in their vagina, again, it's generally these pelvic muscles. And again, it's just knowing, and it's so treatable. So that's about the muscles. In terms of the skin on the outside, I think like you, the most common condition I see is a condition called lichen sclerosis. And I was never taught about this, as a general OBGYN. I was able to go to different courses and learn about it. But I think about lichen sclerosis as essentially the skin on the outside, the vulva, around the clitoris, around the urethra sometimes, and the perineum, in that space between the rectum and the vagina, and sometimes even around the rectum. It's where the skin gets really, really thin. We call it lichen because it can look at times very white, like the moss on a tree. But essentially how I think about it is that it's an autoimmune condition where the skin, the superficial layer of the skin gets almost damaged, and we can see the boards. We can see the collagen, underneath the wallpaper. And so that's where the white change happens. And the skin gets very painful.
And it makes the collagen actually degrades so that the vulvar tissue and the labia become stiff. And because they become stiff, the opening becomes stiff. And so patients come in saying, no way, I can't possibly have sex. And they develop the pelvic floor muscle problems secondarily.
Yeah.
But the instigator is really this vulvar skin condition. Think of it a little bit like eczema, maybe, where it causes a lot of itching, burning, tears. The skin can become thickened or paper thin. And it's also very poorly known and understood by the public. So I'll often see patients who've been to 5 or 6 physicians, and they've just been given yeast medication, and they end up finding their diagnosis online through Reddit or Facebook or websites. You can look up lichen sclerosis, LICHEN lichen sclerosus. You can also look on the National Vulvodynia Association. I think, Dr. Bitner, it's also important to give people the ASECT website to look for pelvic physical therapists in case you don't have a gynecologist who specializes in sexual medicine near you. It's possible. And so if you go on ASECT.com, this is, ASECT will be for sexual counselors. Sorry, you'll have to give them the physical therapy website. Sorry about that.
It's all right. But the other website I always think about too, of course, is NAM. So it's the menopause.org. You can find a menopause certified provider in your area. And often people who are NAM certified are also just very aware of gender specific medicine, and they would know the resources in their area. So anyone in the country could go to menopause.org. The other site is ISSWSH, ISSWSH, or the International Society for the Study of Women's Sexual Health. And these are websites where often you can find a provider in your area who has had extra training in sexual health. But back to lichen real quick too, I think it's really important that people know that once you're diagnosed with it, it tends to be a chronic condition that is there forever. You always have to be aware of it. Always see a provider who's knowledgeable about this. The first line treatment tends to be use of a class 3 steroid, super strong steroid ointment that we just use the tiniest dab. I show patients their bottom with a mirror every time, and we use a Q-tip with just a tiny little bit of ointment, and I show her where to put it, and even she leaves with a diagram to remember how to do that, and we do frequent checkups. And that protocol was developed at the University of Michigan, and we're very blessed that Dr. Hope Hefner developed a lot of those protocols. But again, the other thing we'll talk about in a little bit is the MonaLisa, which, as I understand it, Maria, you know more than I do, but in terms of the study that's going on with Dr. Andrew Goldstein in New York to look at, does the MonaLisa, does it provide lasting benefit for lichen sclerosis?
Well, sadly, we're only going to get this answer retrospectively. So lasting benefit is sort of like the coronavirus and the vaccine protection. We're not going to really know how long a coronavirus vaccine protects us till we look back, several years from now. And it's much the same thing. There are certainly several studies underway now looking at the use of MonaLisa or CO2 laser to treat lichen sclerosis. And And most of them have shown clinical improvement without exception. The rate limiting step tends to be availability. There's only about 1,000 MonaLisas in the entire United States. And there are other types of lasers, but they haven't been as well studied. So part of the issue will be getting availability to people. And we still don't have big, huge studies with 10,000 women in them. Like we do for, Premarin, for example. Premarin vaginal cream was first developed in 1946. So there's very few medications on the market that can claim to have been studied as long as Premarin vaginal cream.
Exactly. But what I always tell patients, first do no harm. So of course I don't want to do harm or also offer something that I don't believe really will work with at least studies that show benefit in it. But to your point, it's, how long are we going to see benefit?
Well,
the other thing about,
you want to let people suffer. That's the other thing is in my clinical, I've been using it for 5 years, and I've had so many patients come for lichen sclerosis treatment who had out and out failed the steroid treatment. They were steroid pickled and the disease was terrible. So you get to a point where you're out of a lot of options. And so because the laser really is so safe and it is efficacious, I think at least you can be honest with patients and say, look, I don't have a 10-year-long study on 20,000 women, but I do have my own experience and the papers that have been published. There are over 44 papers now showing the safety of it. And I do believe that you'd be a candidate for it. Ultimately, it's the patient that will decide, right?
Exactly. And two, it's just for people, in terms of lichen sclerosis, there is a Facebook page for support for patients who have lichen sclerosis. I know people have brought it in that I'm on the website. I imagine you are too. And in terms of being aware and teaching people about their vulva, their perineum, but also to be aware that long-term untreated lichen sclerosis is definitely associated with vulvar cancer. So it's to be very aware if there's a thickened area that's not getting better, if there's an open sore, of course, that's not healing, then so important to see a gynecologist who knows what they're talking about with lichen and get that looked at.
Right. Or a dermatologist. There are dermatologists who, and if you feel you're brushed off, if you feel it was just glanced at quickly and told it was nothing, and you feel that things are changing, you should go get another opinion. I've picked up many cancers from women who said, I'm just coming for another opinion because I felt the doctor just sort of glanced there and brushed me off and gave me yeast medication. And I picked up many cancers that way. So I think it's okay to advocate for yourself.
Good for you. I totally agree, which just brings me, I don't want to forget the question that someone called in with or wrote in with in terms of what's happening. And what's happening is that she said her clitoris is disappearing. She feels like she can't tell where it is. Well, she knows where it is, but it can't actually see it, and the sensation is changing. And I'm sure I have, just like you've seen, where lichen sclerosis or even just genital urinary syndrome of menopause, the hood of the clitoris closes over. And I use the analogy, if you're wearing a hoodie sweatshirt and you tie the hood tight under your chin, you can't pull the head back. You can't pull the hood back to see your head. And so lichen sclerosis can do the same thing, where it causes the hood of the clitoris to kind of stick down on the corners, so then the hood can't pull back. And then of course what can happen is that skin makes white stuff, and so it's not dirty or discharged, is that skin white stuff can get stuck underneath the hood of the clitoris, and it could cause, we call it dermal, I'm forgetting, but like dermal pearls.
Keratin pearls.
Keratin pearls. And it's like little grains of sand that are under the hood of the clitoris. And so not only can it change sensation where women, it's a little harder to get aroused, it's harder to feel anything's going on down there, but it also can make it painful when there's any touch to that area, because again, it's like grains of sand on a very, very tender area. So again, it's so important to make sure you know your anatomy, be able to pull that hood back, and if you can't, ask questions. Don't be shy.
Right.
And then the topic near and dear to our heart, I can't believe it's already been almost a half an hour, but is a condition we call genital urinary syndrome of menopause. So it's about the skin on the inside and the tissues around the bladder opening that are affected by low estrogen. So low estrogen that happens after you have a baby, in the late perimenopause, and certainly in menopause, and becomes progressive after menopause starts. Over 80% of women suffer this condition of thin skin in those tissues.
Right. It's almost ubiquitous because it is actually a sequelae of menopause, and it's chronic and progressive. And this is very different from something like hot flashes, which a woman may experience from 49 to 53, or she may experience
And
for
it might get better. Yeah.
or she may never experience it. But
Mm-hmm.
most women, if you remove estrogen from their genitourinary system, will have some version of this. In some women, it's urinary frequency or urgency. In others, it's recurrent urinary tract infections. In others, it's a reduction in sexual sensation. The clitoris simply shrinks or seems to shrink because the actual nerve endings reduce in number.
And blood flow.
And blood flow, and the blood vessels do too. So we get true anatomic change from the lack of estrogen. And I can't tell you how few women and few physicians and mid-level providers even really understand this. They again link menopause to hot flashes, grouchy behavior, and some hair loss, and can't wait for it to be over. And they don't realize there's this chronic progressive process happening.
Yeah, that happens. And it's just people, again, they think it's just part of aging. They have to live with it. And, oh, I had sex back in the day. I'll never forget. A patient called me, and she was a patient of mine for years. At this point, she's 90, 91. And she went down to Florida for the winter, and she called me. She's like, I met someone. I'm like, you met someone? She's like, I haven't had sex in 20 years, but I think maybe it might happen. And she said, I'm so afraid. I'm just all dried up down there. And I said, well, can your partner still have an erection? How old is this person? 92, and he still can do it. I'm like, okay. So we got her vaginal estrogen. We got her, a milli dilator, and she went to meet him up in Wisconsin to meet his kids, and all was well. They were able to have sex. So
what does a milli dilator cost? I just have to ask.
So it's our list price. I might forget exactly. It's right around $225. And it costs about the same as the set. Now, just like you, I also have in my office Soul Source, which is a great dilator, and it's a set of dilators. So, just like you too, we do a fitting, and we can tell if someone wants either the milli or if they want a couple separate sets. I know what in
Soul
one
Source
set
is about $150. It's less. It's definitely less. Just so that if budget is an issue, I want women to know there are options for that.
And even the lower cost option for a dilator would be, there's one called the Laura Berman dilator. It's at Walgreens for $35. I mean, you get what you pay for, but it's an option, and it's pink plastic, and the pink plastic, like the smallest one, again, it's cheap pink plastic.
Yeah.
But it also, it has different ones that fit on top.
Yeah.
Just like the milli, it also vibrates. And again, it's probably not strong enough to be used to help someone have an orgasm, but it definitely can help those tight pelvic muscles that, again, develop tightness because of pain. So, that can be an option. But again, there's a lot out there.
Yeah.
But, let's talk about, treatment options for thin skin of menopause. Number one, the one we've been using the longest is vaginal estrogen. And you mentioned Premarin cream. There's estrace cream. There's a Vagifem pill, and I would have to say my favorite is Imvexy. Imvexy is like estrace. It's bioidentical estrogen, but it's in coconut oil. It's in a little insert, and that goes up in the vagina right when a person starts. It's every day for 14 days, and then twice a week.
Right.
So there's easy.
Mm-hmm. Super easy to insert, not as messy as some. I know, don't know if you're using Intra Rosa. I use Intra Rosa as well.
Also.
And with all of these, I mean, they do work, but I tell women, unless you have an emergency Wisconsin getaway planned, I tell women, give me 3 months. Give me 3 months to help you, because your tissue has taken 8 years to descend to this state.
Right.
And the cells need 8 to 12 weeks to really get better, to a point you can notice they may start working in a week or two. But when you have to regenerate that many thousands of cells, it's like if we were dyeing your hair 3 hairs at a time. It would take a while. You would really see the gray covered up.
That's a great example.
And the analogy holds true also for when we do the MonaLisa. I tell people we're going to do 3 treatments 6 weeks apart. And then I say, we're going to have to repeat this annually. And they say, why? Does it stop working? And I say, no, it doesn't stop working. Just like if I dye your hair, the dye doesn't stop working, the dye doesn't fall out, but you keep aging and you make new gray hairs. And when you make enough of them, you have to touch up those grays if you want to. But
Love that analogy.
I think it's the same with anything. If you use estrase or Premarin or Intrarosa or Imvexi, these are brand names, by the way, of vaginal estrogen, they will work as long as you use it. But if you stop after those magic 3 months, there will be a slow return to what you were before. So you do have to think of this as a chronic problem. I mean, I think of it like asthma or diabetes. It doesn't have to kill you, but as long as you maintain it. And same with lichen. Lichen is a chronic disease. If you maintain the tissue in a healthy state, you can live your whole life with lichen and never have to worry about the cancer, as long as you have eyes on it, as long as there's a good clinician who knows what lichen looks like that can check it.
With that.
Yeah.
And, again, we've talked about menopause related or dryness related to aging, but also, again, I see a lot of young women like you do, young women who have suffered breast cancer at a young age, even 30 or younger, but also women with anal cancer, or maybe midlife women who have had uterine cancer, and unfortunately it's already spread and they've had to have pelvic radiation. And so, there are a lot of other conditions that are at play. And for example, for some of these women with estrogen dependent cancers that are far enough along, estrogen in the vagina, might not be safe. We know that vaginal estrogen has very little or no systemic absorption. So for many women, it still is safe.
Mm-hmm.
But again, that's where I love offering the MonaLisa. Now, the MonaLisa, of course, is non-hormonal. It's painless, mostly, right? A little uncomfortable on the outside.
Oh, yeah.
But it's especially, even, I've had a patient who, she hears me, she trusts me that vaginal estrogen is safe, but there's just something in her, she just doesn't want to do it. And so I respect that. And again, I love having the MonaLisa because I know it's as effective as estrogen. I love the Velvet trial that shows us that. So the Velvet trial shows us that. I think Maria's frozen, but the Velvet trial shows us that the MonaLisa Touch is as effective as vaginal estrogen, and so we're able to use that in place of for a woman who can't take vaginal estrogen or chooses not to. And the MonaLisa is the CO2 laser that, again, has good research behind it, and that's why I chose to have that laser in my clinic at True Women's Health. Again, the MonaLisa laser, like Dr. Sophocles says, has at least 44 papers that talk about safety and efficacy, and it also is able to be used, again, in 3 treatments over the course of a year, about 4 to 6 weeks apart, and then the last treatment, every year thereafter. And so that's something that we offer in the office. It on the inside, when the vaginal probe is on the inside of the vagina, there's minimal discomfort. And on the outside, when we use it for dryness or lichen sclerosis, we use a numbing cream on the outside that we leave in place for about 20 minutes. We wipe it off, and then we use the laser on the outside. So you've probably noticed we've lost Dr. Sophocles due to some technical difficulties, and we'll see if she rejoins us again. But to kind of finish talking about the MonaLisa, we do have a place on our website at truewomenshealth.com with commonly asked questions and information about the MonaLisa Touch. At True Women's Health, is just like Dr. Sophocles, we offer a consultation to talk about whether the MonaLisa would be the best choice for you. And we go through not only what you could expect, if it would be effective for you, but also we go through some very basic measurements to really measure if it's better for you. Not only does it reduce pain and itching, pain with intercourse, bladder urgency, a sense of dryness, we also measure a pH or an acid level of your vagina, which helps us understand, again, if the MonaLisa is really making a difference. And we also use a vaginal dilator to measure actually, how flexible the opening is. So the condition of the GSM, or vaginal dryness of menopause, makes the tissue not only dry, but it can make it tighter and can make the opening smaller, effectively smaller. And so we measure with the dilator before the treatment and then as treatment goes along. If you choose to sign up for the MonaLisa, we then make those appointments and try to keep them right on schedule with about 4 to 6 weeks apart. And then we would schedule a fourth treatment 12 months from the first treatment, just like Dr. Sophocles said, to make sure that we're maintaining those tissues. And so, that would be an option to further understand if the MonaLisa is right for you. If you have any questions, again, you can go to our landing page, Dr. Sophocles, also to her website. And I believe the MonaLisa Touch has a website, and you can see where there are providers in your area. In terms of, again, scheduling, that's an option. Dr. Sophocles is back. Hello, Maria. Can you hear me? I don't know if she can hear me, so I'll just kind of keep talking. What I want to think about next is that I always like to talk about 5 tips and then 5 tricks, or 5 questions to ask your provider. So first of all, in terms of the 5 tips, number 1, it's to make sure and bring up your concerns about sexual health to your provider. The thing I always say to patients and or to providers, it's okay if doctors or healthcare providers don't know everything. There's so much for us to know and do to provide good, safe care. And so, if the provider doesn't know or isn't comfortable, then ask for a referral. It's okay to say, hey, I understand that maybe you haven't had training in this. Would you refer to me to someone who knows more? So I think that's really important. Hey, Maria, can you hear us now?
I can. I'm back.
Okay.
Yep.
She's back. Okay, good. Tip number 2, there are websites available. One is the ishwish.org. Then there's asec.org to find a sexual health expert, counselor, or therapist. Also, there's a menopause.org website. And I apologize, I don't remember the website for physical therapists. But again,
Get it.
Okay, cool. But providers on these sites and or in your area would likely know a great group of pelvic floor physical therapists. And here in West Michigan, I have several groups that I refer patients to, and I'm really confident they're going to take good care of my patients. And hello, everyone that's watching. Welcome. Tip number 3, if you want to take this one a bit, Maria, understand your family history. How do you use this?
Yeah, because endometriosis, it's not one of those classic genetic things where if your mom has it, you're definitely going to have it. But we do see a family tendency for endometriosis. And I think that's something always to ask a patient if her mom or her aunt or her sister or all of them have had endometriosis. And if she has pelvic pain, especially pain with intercourse, and especially pain that is cyclic, that gets worse just before the period and then seems to get better as she menstruates. That's a very classic sort of pattern of endometriosis pain. That pain is usually with deep dyspareunia, deep penetration. So if someone says, and most of my patients will say their pain is on intromission, on the insertion of the penis, but every so often someone says, no, it's just with deep penetration. That should raise eyebrows for any clinician to be thinking about endometriosis, which unfortunately is not easy to diagnose other than by clinical history or surgery.
And the other point I wanted to make with this is that very often our mothers, our grandmothers, our aunts, our older sisters might have had pain with sex or pelvic pain. And again, just in the past, people haven't talked about this. And so when I see someone who maybe does have children, especially daughters, with these issues, I say, please at some point bring this up with your child, that you've had this issue. If they ever do, it's okay to talk about it. So I also wanted to remember to bring that up.
Sure. And there are cultural issues, Diana, too, that we have to be as clinicians culturally competent and compassionate, and understanding that there are cultures that really don't discuss ever any of this. And so women may come, I have women who are 30 and they're about to get married for the first time and they've never had penetrative sex, which is fine, but they're really quite afraid. They're quite afraid of it. They're afraid because they were told for their entire adult life, don't have sex, you have to wait until you're married. So it brought with it a stigma that there probably is something bad about sex.
Bad about it, right.
And they're really scared about it. So I think we can also, as clinicians, spend a little bit of time trying to understand where they might be coming from, and then, give them permission to say, it's okay to not understand. It's okay to be afraid, and it's okay to worry that something could happen. But let me ask you what you're most afraid of, and then see if I can help debunk some of those myths or just provide a little clarification.
I just love that because I just hate it when people suffer in silence. And again, it's been cultural in many different cultures, to be afraid to talk about it. And I used to think that people didn't want to talk about it because they didn't bring it up, but they were afraid about making me uncomfortable. I'm afraid about making them uncomfortable.
Right.
And it's just amazing how people feel so relieved to be asked, to be allowed to tell their story in a safe space. I tell patients all the time, yeah, I might see your mom, I might see your sister, but nothing leaves this door.
Correct.
This is sacred information. And
it goes for gender expansive populations as well.
You.
I have so many trans patients, and I have gay and lesbian patients, and they absolutely feel, they can sense whether a practice and whether a provider is receptive to them. And since so many providers of our generation, especially, were not trained to discuss this, I think we as clinicians can give off a vibe of, I don't really want to know because I don't really have anything important to say. But this is where going to a practice like True or to my practice in Princeton, New Jersey, I have a rainbow right at the front door. And I think these overt or covert signs that we are willing and eager to talk to a gender expansive population are really welcome, especially today. I think
exactly. And I've really learned, to get more comfortable with it myself. Again, I wasn't trained, wasn't always comfortable asking these questions, but right away, of course, I only take care of female patients or trans, but yet it's, do you have sex with men or women or both? And then just even by asking that question, it's like, oh my gosh, someone is willing to talk about this, or with gay and lesbian couples, it's like, heaven forbid they both go through menopause at the same time. I mean, holy Hannah, right? So it's like, and then keeping some humor about it. Like, let's lighten up about all this stuff. Okay, tip number 4. Be aware of triggers. So I had a patient who was a gymnast, or another patient who did that, ribbon acrobat kind of stuff. She had crazy tight pelvic floor muscles, and it was so painful to have sex. And the pelvic floor physical therapist really helped her not only tighten her pelvis, but also really learn to relax it. But women who drive for a living, is, let's say, doing sales, they're in their car all day, or people who sit at a desk all day and don't exercise, don't stretch, their hips get tight. So it's really important to understand. I don't know what your experience with that is, but it's just so important to think about those triggers.
Yeah, I'm waiting for the research paper to come out on negative effects of chronic Peloton use, because you and I both like spin bikes, and I sit on there sometimes, and I think there is a lot of pressure here. And so we've got to kind of look at that and say, what are we doing? Because we all want to do better and stay a step ahead of the Grim Reaper and exercise. But we do have to remember that there is something called pelvic floor health and vulvar health. And
well, I love to spin, and I think I'm lucky. Just the shape of my pelvis the spin bike doesn't tend to bother it. But again, if I don't do my hip openers and my yoga and my stretches, oh my gosh, can I feel it? And I love how Peloton is just so aware of, really, really promoting stretching after spinning. But, even, I couldn't run anymore because, everything was so tight. So again, it's just, it's to have that maintenance. If we're going to work out, we also have to stretch. That's all about mobility.
Maybe you and I need to do one of these in our workout clothes with a pelvic floor physical therapist teaching us, I think, and teaching the crowd. I don't know that I want to be the demo person.
Yeah, I don't know about that.
We'll be in the background.
Exactly. Okay, tip number 5. When you see your provider, have your questions ready. When people bring their list of questions, they're always apologetic, like, I'm so sorry, I have a list. I'm like, are you kidding me? I love a list. Get out a pen. By the end, I want you to check them all off that we've got them answered. And 2, what I love at True is we've been able to develop an app where you can text us 24/7, with questions right on the app. And so as you think of those questions, maybe even afterwards, you can right away text them to us. But when you see your provider, right, Maria, I think you love that too.
I love it. I sit them down. I sit next to them. I have 2 chairs in my examining room so that they don't feel they're on an examining table. I sit next to them. Well, with COVID, I can't sit quite as close, but and we go through the list together. And again, it gives them permission. And they always say, well, I'm sure these are stupid questions. And they already know they're not. They're not. There's no stupid questions.
No.
And so we encourage that. And also, what about the sex deck? You should mention that.
Oh, that's right. The sex deck, I don't think I have one right here, but people can go on our website. The sex deck is a card deck that I developed. It's the 27 reasons for low sexual desire, and they're color coded for physical, psychological, and interpersonal or relationship issues. On the front of the card is the reason for low sexual desire, and on the back is why it happened and what to do about it. So, for example, painful sex or vaginal dryness or lack of intimacy, distraction, bladder incontinence. It really doesn't feel sexy to leak urine when you're having sex. So,
Right.
That can be a reason that you don't want to do that. So it's just going through that. And it's been such a great conversation tool to use between myself and my patients, but also for patients to take the sex deck home and use it to talk about sexual health with their partner without the shame game or whose fault it is. It just talks about it with issues and kind of takes away that blame game.
I think it'd be neat even for women to have like a girls' night when we do those again and bring it up. I think fostering free and open and non-judgmental discussion about female sexual function and issues is so underdone in our kind of male-dominated society.
But I'm laughing because one time I was at a parents' dinner for one of my son's basketball teams, and the conversation kind of stalled because no one really knew each other. And I pulled out, of course, the sex deck. So I put the sex deck down, and people start looking at the cards, and they handed me cards, and I'm like, dude, I so didn't want to know that about you as I'm sitting in the stand.
TMI.
So, there's time and place for the sex deck.
Right.
But it's a really good tool to get things going. All right, let's go to 5 questions to ask your provider. Again, I want all of you to be, empowered to ask these questions and not feel shy. So number 1, I have concerns about sexual health, including pain. So if this is you, ask your provider and then ask them, are you comfortable talking about this? And if they're like, well, okay, cool, send me to somebody. I am sick of suffering. Maria, what do you think about that?
I mean, you're saying these are the top patient questions?
Yeah, these are patients, questions I want them to ask their provider. And then the next one, question number 2, is if you're comfortable talking about sexual health, what's your background? Have you had training? And again, it's no shame if the provider, they might be in the throes of their career delivering babies and doing surgery. They might not be comfortable. So it's okay to ask if they actually have background or training.
I think it's okay to ask. Sadly, I think I'll speak for physicians. I won't say for nurse practitioners and PAs, who I find to be much more open and honest about what they know and don't know. I think we live in a society where doctors have always had to be right and always had to be the smartest person in the room and worry so much about either getting sued or about losing a patient that they have a hard time. They tend to more sort of brush it off and say, well, you'll be fine. It's a chapter of life, or drink some wine. I have many patients who come to me saying they asked their doctor this, and the doctor said, just drink some wine before you have sex and you'll get through it. And I think luckily most women kind of know that's an answer where they've been brushed off. And so they end up going online and looking up sexual medicine or ISWISH or something like that. But I think the fact that you can guide women to ISWISH or NAMS or to TRUE, or to good practices nationally, I think that's helpful because I think they get brushed off, to be honest. I think it's very hard for women to ask that question. I love the idea of you and I empowering women to go to their GYN and say that. I think it's pretty hard for most doctors to actually admit they don't know a lot about a certain topic. I hope so. I hope I'm wrong. No,
I unfortunately, I don't think you're wrong. But again, even if we can kind of create the environment where, again, this has got to come from women. This has got to come from the grassroots. And so we can do our best to, educate colleagues. But again, it's about staying in our lane. And so, I'm not going to do hip surgery, right? So it's like, how can we all stay in our lane and really do good care? For question number 4, it's, if you have a specific concern, again, it's okay to ask why. I don't know about you, but I'm a bossy Dutch girl. Don't just tell me what to do. I want to know why you're recommending something. So I want to know why I'm having pain. And again, if the provider doesn't know, keep pushing. Be the squeaky wheel.
But I think it's okay I'm going to take the flip side just for those patients who are going to say, well, I don't feel comfortable, also to advocate for themselves. So we share that desire for our patients to advocate for themselves. But you have to remember that sometimes clinicians don't have a why. We especially with chronic
Correct.
pelvic pain,
Yep,
we
exactly.
can't always say it's an infection or it's genitourinary syndrome of menopause or
Right.
it's endometriosis. So just beware that especially chronic pelvic pain is there's not always an answer that we can give you. But a
Agreed.
good clinician will explain that these are 5 things it could be, and these are why
And
I
we're going to
think it
make
could
sure they're
be.
not. Right.
Mhm.
I love it. Exactly. And then for specific concerns, again, what are options to feel better? And, there definitely are specialists, especially for the patients, here in town, we have someone who really does a lot of work with the National Chronic Pain Association. And so it's really, really important to have someone who knows even just the next step, So, all really good stuff. So
Yeah.
everyone, I can't believe we've been here for almost, 45 minutes. And it's just been such an honor to talk to you and have Dr. Sophocles join us from New Jersey.
Thank you so
Uh,
much.
Thank you so much for joining us. And if people have more information, you can find Dr. Sophocles at her website, which is up on the screen at PrincetonGYN.com. Sorry. And then, of course, TrueWomen'sHealth.com is the website where you can learn more about our practice. We're both active on social media, Facebook, Instagram, Twitter. I don't know how much Missy we've been on Twitter lately, but yes. So we really want to join the conversation and be the source of truth. And so, when you find stuff on either of our sites, they're evidence-based. We have good experience in these, and we really just want to help you feel better. So, Christy Todd, thank you for that compliment.
Yeah.
We just love what we do.
We love what we do, and we care about you. So reach out to us.
Great. So thank you, everyone. Have a good night.
Thanks. Good night.